My topic for today is balancing act anesthesia and electrolytes. To begin with, what are the electrolytes? They are the essential minerals that are charged molecules. They are present in body fluids, which compromises 60% of the body mass, and they maintain most of the physiological functions of the body. Where do they come from and where are they placed? They basically come from the foods and the fluids, and they are placed inside of the cell or outside in the body fluids. And they are also placed in the bones like calcium. Why are they important to us? They maintain the metabolic balance for optimum functioning of the body. Their imbalance disrupts the carbohydrate, protein, and fat metabolism, which will lead to abnormal glucose levels, ketones accumulation. They're important for physiological function of the vital organs like heart, kidney, and muscles. What controls their level? So serum electrolyte balance is regulated through a complex interplay of hormonal mechanism, renal function, and physiological responses. We all know that hormonal regulation like aldosterone stimulation causes sodium reabsorption in kidneys and potassium excretion. Similarly, antidiuretic hormone that is released causes the in response to the osmotic balance of the blood will cause the fluid regulation. The natriuretic peptide like atrial natriuretic peptide, which is released by the heart in response to the blood volume and blood pressure. They will also promote the sodium excretion by kidney, counteracting the effect of aldosterone and helping reduce the blood pressure. Parathyroid hormone, which regulates the calcium and phosphate levels in the blood. The renal function, basically, in response to hormonal regulation, works by filtering reabsorption and excretion of electrolytes. And there are physiological responses like increase in the sodium level in the body causes thirst mechanism, making the person thirsty and then restoring the fluid balance. And the cellular ion exchange. The electrolytes move across the cells easily and they form the balance between the intracellular and the extracellular milieu. These are the normal levels of electrolytes. I will not go into detail of this. We all know those normal values, and we are going to discuss four main electrolytes today. What causes the imbalance? Any major fluid shift causes the imbalance, like dehydration, GI disturbances like vomiting and diarrhea, or in burns. Chronic illnesses like kidney failure, chronic alcoholism, and some drugs like diuretics, antibiotics, or corticosteroids, which cause sodium retention, potassium loss. These all cause the imbalance. How is anesthesia and electrolytes related? We all know that drugs like succinylcholine causes hyperkalemia, and inhalational agents are known to cause vasodilatation, hypotension. They activate the renal system and thereby causing reabsorption or excretion of electrolytes. Also, antidiuretic hormone is secreted in response to stress stimulus during anesthesia. General anesthesia is also known to decrease gastric motility, which disrupts the absorption of electrolytes from the foods. There are indirect effects like activating the neurohormonal sympathetic triggering of the systems. Then the fluids that we use in anesthesia are all basically electrolytes. Mechanical ventilation, like hyperventilation, causes respiratory alkalosis and shifts the potassium into the cells, causing hypokalemia. Even the studies on the dogs has shown that presence of hyperkalemia, the bupivacaine cardiac toxicity is manifested in half dose than the normal dose. So even local anesthesia makes a difference when there are electrolyte imbalances. We are going to see them in individual. Begin with calcium. It is a major part of bone and teeth formation. 99% of the body's calcium is in bones and teeth. Then it helps in muscle contraction, blood clotting. Calcium plays a critical role in coagulation cascade. It is required for activation of several proteins involved in the blood clotting. Then it is very essential for neurotransmission, hormonal secretion, and calcium helps to maintain the normal heart rhythm by regulating electrical impulses. Hypocalcemia, the causes are kidney failure, parathyroidism, vitamin D deficiency, pancreatitis, prostate cancer, malabsorption. 80% of the calcium is bound to albumin and only free calcium is in active form. So functionally, it doesn't matter, but it gives a false hypocalcemia results when there is a nephrotic syndrome or chronic liver disease and there is a hypoalbuminemia. Some drugs also cause hypocalcemia, like chemotherapy drugs, anticonvulsants. Also, the alkalosis decreases the free calcium. So pH correction has to be done prior to the calcium correction. Symptoms of hypocalcemia there are muscle cramps, numbness and tingling in the fingers, abnormal heart rhythm. There is always exaggeration of myocardial depression and hypotension caused by anesthetic agents when there is preceding hypocalcemia. There is increased risk of fractures. Long-term deficiency causes osteoporosis, particularly in the postmenopausal women. Also, neuromuscular blocking agent monitoring is affected when there is hypocalcemia. Treatment of hypocalcemia, the oral supplement calcium gluconate can be given at the rate of 1.5 to 3 milligrams per kg per hour. The safe target is typically not to exceed the increase more than 1 milligram per deciliter per day in total calcium. Vitamin D supplement and magnesium. The magnesium is important for parathyroid hormone secretion as well as kidney regulation of calcium. And symptomatic severe hypocalcemia presenting with tetany or cardiac arrhythmia needs to be corrected by IV administration. So basically, calcium and magnesium go very much hand in hand and they need each other for even correction purpose. Hypercalcemia, the causes are kidney diseases, hyperparathyroidism, lung diseases, sarcoidosis, certain type of cancer, excessive use of antacids and or excessive calcium and vitamin D supplements, medications like lithium or theophylline, and acidosis. Symptoms of hypercalcemia, there is excess calcium can cause constipation, nausea, vomiting, kidney stones, impaired kidney function, and cardiac arrhythmias. Treatment of hypercalcemia, basically restoring the hydration by initial treatment for hypercalcemia and medications like biphosphonate, calcitonin, and corticosteroid. Calcitonin can provide rapid but temporary reduction in the serum calcium level. Corticosteroids are particularly helpful in cancer-related hypercalcemia. Dialysis in severe cases is needed for correction of hypercalcemia. Now to potassium, it regulates the heart function and helps maintain healthy nerves and muscles. Hypercalcemia, it is fatal when it is left undiagnosed and untreated, and it is typically triggered by severe dehydration, kidney failure, severe acidosis, including diabetic ketoacidosis, certain antihypertensives and diuretics, and adrenal deficiency when your cortisol levels are too low. Treatment of hyperkalemia, the severe hyperkalemia, which is potassium more than 6, or those exhibit ECG changes, intravenous calcium gluconate 1 to 2 gram IV over 5 to 10 minutes, calcium chloride 500 milligram 1 to 1 gram over 5 to 10 minutes. Insulin and glucose, that is 5 units with 25% milligram of glucose. Initially, the standard treatment included 10 units of insulin. Now the studies have confirmed that the 5 and the 10 units give similar result when it comes to reducing the potassium, but 10 units certainly causes more incidences of hypoglycemia and it is not recommended. Repeated doses can be given. Basically, diuretics can be given. Dialysis in severe cases has to be initiated, and drugs that bind the potassium in the gut. Hypokalemia causes are eating disorder, severe vomiting or diarrhea, and certain medication including laxative, diuretic, and corticosteroids and insulin. Signs and symptoms of hypokalemia is weakness, leg cramps or paresis, and ascending paralysis which can be fatal when there is a respiratory compromise. Also paralytic ileus, metabolic acidosis. There can be ECG changes like U wave, T wave flattening, and STT changes, and cardiac arrhythmias. Now, treatment of hypokalemia is oral potassium. For mild to moderate hypokalemia, the dosage is 40 to 100 millimoles per day. IV potassium, the standard infusion rate is 10 to 20 millimoles per hour with continuous ECG monitoring, which is required for severe hypokalemia less than 2.5 milliequivalent per liter or symptomatic cases, and addressing the underlying cause like discontinuation of the drugs that cause excessive excretion of potassium, for example, insulin. Now, to restore the potassium, we need to calculate the potassium deficit first. These all formulas are available on the internet or in the apps, we can use it. But potassium deficit has to be calculated by desired potassium minus measured potassium into the body weight and into 0.4. And desired potassium is typically set for 3.5 milliequivalents per liter. The daily potassium requirement has to be calculated, which is 1 into body weight, and which needs to be added with the potassium deficit for total potassium requirement calculation. Coming to sodium, it's a cation, it's extracellular ion, which is kidney regulated, maintains the serum osmolality, maintains the membrane potential. We know action potential is generated because of sodium and potassium interplay. Absorption of glucose, chloride, and amino acid is regulated by sodium as well. Hyponatremia, it's the most common electrolyte imbalance, majorly caused by vomiting, diarrhea, poor nutrition, overhydration, which is dilutional hyponatremia, thyroid or adrenal disorders, liver, heart, kidney failure causing fluid accumulation, drugs like diuretics, or syndrome of inappropriate secretion of antidiuretic hormone. Treatment of hyponatremia. The symptoms, severe cases can lead to confusion, seizures, muscle cramps, and coma due to cerebral edema. The treatment is correction of fluid balance, restoration of fluid, restricting the fluids in case of dilutional hyponatremia, treating the cause, and slow correction with 3% normal saline. Now, formulas for correcting sodium level are in 3 steps. First, we need to calculate the sodium deficit, which is total body water in liters into desired sodium minus measured sodium. Total body water in men is 0.6 into body weight, and in women is 0.5 into body weight. Desired sodium is set at 140 milliequivalents per liter. We have to calculate the volume of the hypertonic saline that would be needed. So 3% saline composition contains approximately 513 milliequivalents per liter of sodium. So volume of the 3% of saline in ml will be sodium deficit as we calculated previously, divided by 513 into 1000. While using hypertonic saline, the volume required to achieve specific increase in the serum sodium has to be estimated. Rate of correction also matters. Rather, it is the most important part of correction. It should not exceed 6 to 12 milliequivalents per liter within first 24 hours. But in severe cases, more rapid correction may be necessary, but it should be approached cautiously to avoid complications like cerebral osmotic demyelination syndrome. This demyelination syndrome can be present in patients with chronic alcoholism and malnutrition. So in those patients, even slower correction of sodium is required. Hypernatremia, serum sodium level exceeds 145 millimoles per liter. The causes are dehydration, loss of water from the body, and inadequate water intake or drugs. The symptoms are thirst, restlessness, confusion, muscle twitching, seizures, and potential coma. Treatment of hypernatremia is oral hydration. In severe cases, IV replacement of the fluid. 5% dextrose is choice of fluid. A 0.45% sodium chloride, that is half saline, can be given in chronic hypernatremia. Again, it is crucial to correct hypernatremia also slowly, not more than 0.5 milliequivalents per liter per hour, and maximum of 10 to 12 milliequivalents per liter in 24 hours to avoid the complications like cerebral edema. Coming to magnesium, its major source is diet, and it is a vital electrolyte when it comes to muscle, hearts, and nerves. Role of magnesium in anesthesia, particularly, it has analgesic properties. It helps in muscle relaxation. It has cardiovascular effects, like it acts as a calcium channel blocker, helps in stabilizing cardiac membrane, reduces the incidences of arrhythmias. It can attenuate a cardiovascular response to intubation and surgical stress by inhibiting catecholamine release and thereby minimizing fluctuations in the heart rate, blood pressure, and so the renin-angiotensin system also less activated, causing the electrolyte balance. It also decreases the post-operative nausea, vomiting. It helps in bronchodilation. Hypomagnesemia, it is common in alcohol users. Gastrointestinal conditions can cause magnesemia, excessive renal loss of magnesium, and drugs like omeprazole. Signs and symptoms, ventricular arrhythmias, torsade, we all know that, nausea, vomiting, lethargy, weakness, tremors, and in association with concurrent hypocalcemia, there can be a tetany. In presence of hypocalcemia, tetany can occur during the administration of magnesium sulfate if the calcium is not supplemented, as ionized calcium levels can drop acutely from complexing calcium and sulfate and increase the urinary excretion. Treatment of hypomagnesemia, oral magnesium supplements, intravenous magnesium of 1 or 2 grams over 15 minutes for severe symptoms, and for non-emergency replacement, 4 to 8 grams over 12 to 24 hours. Continuous monitoring of serum magnesium level is essential during the treatment, especially in patients with renal impairment. Addressing the underlying cause where the drugs are concerned and dietary modification. Treatment of torsade. Magnesium sulfate can be given 2 grams IV over 1 to 2 minutes. This is considered the first line treatment of torsade, and it is effective even in the patients with normal magnesium level. Redosing, if the initial treatment is ineffective, second bolus can be given after 5 to 10 minutes, followed by an infusion of 3 to 20 milligrams per minute as needed. Hypermagnesemia causes a renal failure, excess magnesium replacement, use of magnesium containing laxatives and antacids. Signs and symptoms are bradycardia, weak and steady pulse, hyporeflexia, muscle weaknesses, and cardiac arrest. Treatment of hypermagnesia, increasing the fluid intake, discontinuing the magnesium containing medications, hemodialysis, or peritoneal dialysis. Additionally, calcium gluconate can be helpful to reduce the cardiac effect of hypermagnesia. IV fluids, these are mainstay of our treatment on everyday basis. We all use the IV fluids, which are particularly made of all the electrolytes. Coming to isotonic crystalloids, that is ringer lactate, which contains sodium, chloride, potassium, calcium, and lactate. It is preferred due to its balanced electrolyte composition, which is closely resembling plasma. It is ideal fluid for fluid resuscitation and maintenance in surgical patients, especially who are at the risk of metabolic acidosis. Normal saline like 0.9% sodium chloride, which contains sodium and chloride, which is used as a replacement fluid. However, it can lead to hyperchloremic metabolic acidosis if used excessively. It is generally not recommended for long-term maintenance due to its high chloride content. Dextrose fluids, which are basically of nutritive value, it provides calories when the patients are fasting who are unable to take oral nutrition, but it does not provide any electrolyte and should be supplemented with the electrolyte solutions. And there are balanced crystalloids like plasmalite, which contain sodium, potassium, magnesium, and acetate. And nowadays, even the colloids that are with electrolytes are available like volulite. So my take-home message is, though they are tiny molecules, serum electrolyte make a big difference in maintaining the homeostasis of the body. There is a complex interplay of all the systems with huge dependency on each other while maintaining this balance. Timely restoration of electrolyte balance is crucial, and anesthesia is closely related to this balance or the imbalance. Thank you everyone for patient listening, and happy and prosperous Diwali.